Okay, well, this is an option that we were considering a few months ago. We were looking for patients to try the possibility to do a HIFU ablation with the floating technique that Dr. Wolfgang commented previously. But this is the case that we're going to present, and you'll see. So this is a male, 44-year-old, with a synovial sarcoma on the right side in 2007 that was operated on. Then he had local recurrence in 2013, surgery plus chemotherapy. Another lung recurrence on right lung in 2015, surgery plus chemotherapy. Another metastasis on the left lung in 2016, surgery plus chemotherapy. Another metastasis on the left lung again. More surgery, more chemotherapy. Another recurrence on the left lung in this year, 2 lines of chemotherapy, progression, then stable disease. And now we are in a middle of stable disease, slow progression. So this patient consulted us to see if we could do something for him. So it's an off-label consideration to do that. We were commenting that with the thoracic department, and we decided that we could at least try to reduce the bulk of disease and try to generate one of all these immune responses that we have when we're doing this. So this is the ultrasound image on this case. You'll see it better when we see the CT scan. This is a tumor that is very anterior, so we can see here that the tumor is very close to the front part of the left rib cage. It's a mediastinal and anterior tumor that's also close to the vessels. And this is what we did. So we see here on the front thorax of the patient this little tape that help us positioning when we do it over the transducer. So the patient is in a prone position, and what we do, we have the ability to move this transducer back and forth, and also to move with this the bed in order to treat between the rib spaces. This is how we see it. As I have commented in another time, what we do here is we have the ultrasound backwards, and then we try to make in the brain of the operator the fusion of the images with the ones that you see on the treatment device. And this is what we see when we treat. So this is the images, and we treat with these different sections. So we see here that this is all the sections that we have done. So those are 5 millimeter sections, are 11 sections. So we covered around 55 millimeters of the tumor, not all the tumor, but the nucleus of the tumor. So in this case, because the tumor was very anterior and we were able to do it without using the floating technique, that we were ready to install if we were needed to do it, but we didn't do it this time. We didn't record any complications during the procedure. The procedure lasts around 2.5 hours. The skin was preserved. There was a small tissue edema. Patient was under analgesia for 24 hours after the procedure, was discharged the next day. At 4th day, the patient called us with small hemoptysis with no systemic consequences. The patient is still doing well. And while we conclude that, and in this case, under favorable conditions, we could do this type of ablation, and we're planning to pursue with more cases and also to use the floating technique if we need it. And this is the ultrasound after the procedure, 48 hours after this procedure. Thank you.
Questions?
Great case. Well, yes, go ahead.
Thank you.
The lesion was largely necrotic. Did you put the target of the sonications on the periphery, or did you go inside?
Inside.
In the middle?
In the middle.
Did you see any difference while targeting specifically necrotic or vital tissue? I'm referring on the CT images.
Yes, we only have this ultrasound. We decided to do a PET scan in a few weeks, and we will report that when we have the full information. But that case was done 10 days ago, so we don't have more images. But we saw when we were doing the procedure, the response. We see the white response of the ablation, and we saw it when we not in the necrotic part, in where it was viable tissue.
Okay.
That's an assumption, I think.
And I think one more thing to consider as we're getting into new areas of potential combination drug device immunomodulation and checkpoint inhibition has made such advances in oncology world we heard about yesterday. In a setting like a lung cancer that's already got checkpoints indicated, already has roles for the drugs, it's not too much of a stretch to get to clinic with a subtotal ablation. You don't need to ablate everything to vaccinate or potentiate T-cell maturation. You have a small ablation. And so from clinical work in the liver with other modes of ablative therapies and checkpoint inhibition, which impacts liver cancers, I can say that small ablations in large tumors can work systemically.
Yeah.
So that's kind of the cool thing about
this is our hope in this case. Thank you.
Other questions? Awesome. Thanks for your patience. On to coffee.
Thank you.